This is Blood and Cancer, the official podcast of MDH Hematology Oncology. I'm the voice of MDH podcast, Nick Andrews, and I'm joined, as I always am, by MDH Editor-in-Chief of Hematology Oncology, Dr. David Henry. Dr. Henry, how are you doing?
Nick, how you doing? Good evening to you.
I'm doing pretty well. I just heard a rumor about you and your family.
Well, the rumor is true.
It's true.
I'm sure many of our listeners listen to or watch Family Feud, and we often watch it over the dinner hours. So not quite a year ago, they had an open casting call in South Philadelphia at an airport hotel to anybody who wanted to try out. 150 families tried out. And of course, my two kids and their cousins made it.
Wow.
And they were flown to LA a few months ago. They're sworn to secrecy. I don't know what happened, but it's playing this week. And tonight's the second night. They've won a second night, so they keep playing until they lose. So we're glued to the TV at dinner time.
That is amazing. That is an all-American classic. I'm going to tell my dad about that. He will be quite jealous. I have been told that I would have to audition for my spot on Family Feud in my family. I don't have a lockdown.
I'm terrible.
Yeah, but, I don't know. That's not for me. But let's take a look at what's going on in Blood and Cancer as David takes a backseat to his super famous family. This week, as we head into fall, clinical correlation, of course, coming up after the interview. This interview is an update from the American Society of Clinical Oncology about VTE prophylaxis with one of our favorite people coming out of ASCO. And important topic, and anytime you get updates out of ASCO, very important.
Yeah, so Dr. Alok Khorana is our interviewee this week, and he was actually second author on the ASCO updates, which came out on venous thromboembolism and prophylaxis. So we know from previous interviews and from previous guidelines that this is an important topic. We know what to do with people who are inpatient or people who are have a DVT-PE, but what about prevention in the post-op setting? What about the outpatient setting? So this is really relevant. You'll hear me talk about, for example, pancreas cancer, metastatic to liver. I routinely put such patients on some kind of prophylaxis since it's so high. He agreed with me, said the guidelines recommend that. And the new thing, which we'll get into, is you can do this with pills. Some of the DOACs, the direct oral acting anticoagulants.
Yeah, of course. And that's been a hot topic in cardiology here at MDH for the past about 18 months or so, and big breakthroughs for sure. Coming up later with clinical correlation, Dr. Yurkiewicz stuns us again, but this time, in my opinion, it's quite simple. And it's when patients ask what they can and what they should eat to improve their situation and to help their outcomes. I think it's so fascinating because it's such a small thing, but if I were diagnosed with cancer, I would feel like my diet was something that I can control.
Exactly right. And so you finish the first visit or second visit with a patient, new diagnosis going forward. We're going to do this. We're going to test that. We're going to give you this, do that. And the patient's thinking all along, what should I do? And so often diet comes up. And this is why in most cancer centers, a dietitian is handy, a nutritionist. And so we say, oh, yes, right. We'd like you to eat more of this and less of that. Of course, bowels and bladder are important functions that can be related to that. So she covers a very important topic. Most cancer centers do as well have a nutritionist to cover this.
Which is it's so important because I think that there is perhaps a placebo effect here as well, where he's like, I go home and I feel like I've been dealt this really crappy, pair of cards, and maybe if I eat nuts and have the right diet, then I can feel like I'm in a better place. And if it can also improve your outcomes or improve how you deal with treatment in any way, then that's obviously a really important thing for patients to understand. So
very, very important.
Unbelievable job by Ilana. That's coming up after our interview, of course, but let's take a look at what's going on this week in hematology oncology. And it's a bit of a heavier news item. The FDA is warning that the entire class of CDK4/6 inhibitors, that's cyclin-dependent kinase inhibitors, that's used to treat advanced breast cancer may cause rare but severe inflammation of the lungs. David, this is a pretty big deal.
It's a very big deal. I think when a new drug comes out, it's a new class for the past couple of years. There's 3 of them on the market. We use all of them virtually all the time now to enhance the aromatase inhibitor effect. And the clinical trials that are done usually involve hundreds of people. Well, once a drug is approved on the market, it involves thousands of people, so rare side effects you'll now start to pick up. Fortunately, the FDA has this nice reporting mechanism, so this alert must have triggered their enough patient reporting to let us know that this can occur: interstitial fibrosis, inflammation in patients taking these medications, albeit rare, but something to be aware of.
Right, and I think the most important takeaway here, at least from where I sit, is that the overall benefit of these drugs, the CDK4/6 inhibitors, is still greater than the risks, and that's something that can be used to reassure patients.
Very important to mention as well, just so what an alert says. So we should be aware, but not afraid to use these drugs because they make a big difference.
All right. Well, if you want to learn more about the alert or stay up to date on the latest in hematology oncology from around the United States and around the world, you can find a link to that in the podcast notes, and we've got everything up to date. Of course, Dr. Henry is the editor-in-chief of our online publication, MD-Edge Hematology Oncology. So without further ado, Dr. Henry, let's get to this interview from ASCO Update.
Sounds great. Let's hear it. Welcome to this podcast. I'm Dr. David Henry, host of this podcast, Blood and Cancer, also editor of the online journal mdedge.com/hematology-oncology. And I'm really delighted today to have a guest we had before, and he's back by popular demand, Dr. Alok Khorana, who's professor of medicine at Cleveland Clinic, and we're going to talk about venous thromboembolism. Alok, welcome back to the podcast.
Thank you. Delighted to be back.
Well, and we're delighted to have you back. So what we were talking about before, of course, in the context of oncology, coagulation, abnormal coagulation, venous thromboembolism is a not infrequent problem and theme. And so earlier this year, we talked about the things we do in hospital and when we treat patients with venous thromboembolism, a little bit about the increased risk some of our patients have. And of course, we'll review the Khorana score, which I find very helpful to guide us as to higher risk and to do some prevention. And then I think based on some of the data which Dr. Khorana generated, ASCO did a publication update to the venous thromboembolism guidelines recently this summer in August 2019. So what I thought I'd do is just say, and we can comment as I go on what we do, and then I'll go point by point what ASCO says, let's make it an official recommendation. So anybody admitted to the hospital, cancer or not, of course, we put them at rest and we give them some kind of heparin anticoagulation usually. Anybody who has a venous thromboembolism, DVT, PE, outpatient setting, we treat, and inpatient setting, we treat. But then, of course, missing from that is what about the patient with pancreas cancer, metastatic to liver, who I find in my clinic is very high risk, and we'll go through that kind of risk with the Khorana score. And some of the data recently generated by Dr. Khorana and also Dr. Carrier has led to, I think, the update of these guidelines. So let's go through what they say, and Alok, you can comment as we go along. So here it says in their recommendation, which came out in August and was published in JCO, changes to previous recommendations. I'll read the first line. Clinicians may offer thromboprophylaxis with apixaban, rivaroxaban, or low molecular weight heparin to select high-risk outpatients with cancer. So let's pause on that. Who are those high-risk outpatients with cancer?
So, right, this is really a timely discussion because update hasn't been around that long. It's actually only been a couple of weeks, so you're very astute in picking that up and having us discuss it. The update doesn't necessarily follow from the Cassini and Everett data. There was actually a planned update for this year, and it focused on both treatment aspects, which I'm sure you'll get to in a second. But then the Cassini and Everett data sort of came out simultaneously, and so the update incorporated that. And so it happens to now be sort of the most updated guideline on this area. The recommendation you're referring to is in answer to the clinical question. So ASCO guidelines are framed around specific clinical questions, and the clinical question is, should ambulatory patients, and when they say ambulatory, they really mean outpatients, people who are in the community and not necessarily admitted to the hospital, should they receive VTE prophylaxis with an anticoagulant while they're getting systemic therapy? The reason that population is important is because most DVT or PE in cancer patient no longer occurs in the hospitalized setting. It occurs in the outpatient setting.
Yeah.
It's between 75 and 80%. And so, if you're thinking about this from a public health perspective, where we all agree that DVT or PE is bad, we want to try and reduce it, we can be 100% compliant with inpatient prophylaxis and post-surgical prophylaxis, which is really, when you think about Joint Commission and all these regulatory agencies, that's what they're focused on. If you're 100% compliant with inpatient or post-surgical prophylaxis, you're still only preventing 20 or 25% of all VTE in cancer patients because most of it occurs in the outpatient setting. So this question really asks, the question posed here is actually referring to a large public health problem, which is, are cancer patients, that are at risk for VTE, DVT or PE, how can we prevent that from happening? Before I get to sort of the specific phrase you quoted, it's important to note that the first recommendation in response to that question, should ambulatory patients with cancer receive prophylaxis, should not be offered to all outpatients with cancer. And I can't sort of stress that enough, because as we recognize that there are cancer patients who, in general, cancer patients are at risk for DVT or PE, that risk is not equally distributed across all cancer patients.
Yeah. Mm-hmm.
And you mentioned pancreas cancer. I think that's a great example of a tumor that has a very high risk. But the contrast to that would be, somebody with breast cancer that's on aromatase inhibitor or something.
It has maybe a bone metastasis or 2 or 3 and not as high a risk.
Exactly. So the first response is don't give it to everybody. And I 100% agree with that.
Okay.
The second recommendation is that high-risk patients, and they define it as in the ASCO guideline as a Khorana score of 2 or higher, and that's based on the Cassini and Evert data that came out earlier this year, may be offered prophylaxis with apixaban, rivaroxaban, or low molecular weight heparin. The low molecular weight heparin recommendation is from a prior recommendation because there's been trials of outpatient thromboprophylaxis with low molecular weight heparin. There's been 2 really large studies across different solid tumors where the rates were about 3.5% down to about 1.5%. There's been 2 pancreas cancer specific trials where the rates were much higher. They're like 25% down to 10, 12%, somewhere in that range. And so because there were these pancreas specific trials, and pancreas cancer patients automatically get a score of 2 in the Khorana score, so you end up with this recommendation where they say it's okay to give low molecular weight heparin, it's okay to give apixaban, and it's okay to give rivaroxaban. The term here, people sort of read through these guidelines, but I've been on many of these guidelines panels. I've actually done a lot of work for ASCO guidelines, and so the wording is really important. And the wording here is may be offered, as the other option would have been should be offered. And so it's couched a little bit more carefully as may be offered. And I think that's a reflection of the fact that these are new data. We are still digesting them. There's a lot of subgroup analyses that are continuing to come out from both these trials. And we didn't, I'm speaking for myself and not for the whole panel, but I think the general understanding was we don't want to make sort of a mandatory recommendation without, letting the community absorb sort of all of this data.
Could I interject here before we go further? Can we define for listeners the Khorana score? Can you remind us of the score?
Right. So the score is based on 5 simple clinical and lab variables. One is the type of cancer. So if you have pancreas cancer, as I mentioned, or stomach cancer, you get a score of 2. If you have other lab abnormalities, so a low hemoglobin, less than 10, a high leukocyte count, more than 11, a high platelet count, more than 350, or a high BMI of more than 35 kilogram per meter square. Each of those variables gets 1 point. And then there are some types of cancers like lung cancer where you get 1 point instead of 2 points. And high risk in the original score was defined as 3 or higher. And that had been sort of discussed in the last ASCO guideline. But Cassini and Evert both took 2 and higher as the cutoff and saw substantial rates. And so for this iteration of the ASCO guideline, that cutoff has been revised downward to 2 and higher rather than 3 and higher. So what that would mean would be any pancreas patient, for instance, would automatically qualify just based on having pancreatic cancer.
Right, yeah. And that would be with or without metastases?
That would be with or without metastasis. But this is at the start of a system. So these are not patients that are, had surgery 2 years ago and are in remission. So these are patients at the start of an
active patients. Okay.
Treatment regimen, right, exactly. Yeah.
Well, as an aside, I've seen literature in the past, chemotherapy itself is somewhat thrombogenic. Your guideline can only include so many predisposing features, but I don't suppose anyone's teased that data out. The pancreas cancer patient with or without metastases, not on therapy, we really, it's too little wiggle room in there to include the chemotherapy or not?
We did. So when we developed the score originally, we actually did look at the types of chemotherapy regimens because we had access to that information. This is back in the mid 2000s, and so it didn't include many of the current treatment regimens, but we had the cisplatins and definitely the older chemotherapy regimens. The challenge was that, so we actually, when we were developing the risk score, we ended up with a couple different agents that seemed to be at high risk. The challenge was when you threw that into a multivariate model, there's such a close link, for instance, between gemcitabine and having pancreatic cancer, or cisplatin and having lung cancer, that sort of one threw the other variable out. So if you kept the type of cancer in there, the specific chemotherapy agent didn't seem to matter.
That was stronger. Well, let's and I should mention as we go along, you are a second author on these updated guidelines, so you helped greatly contribute. So as we continue down the changes as it's coded in this ASCO update, it says patients with brain metastases are now addressed in the VTE treatment section. I've always thought as anticoagulant, for example, you have a PE, you have a DVT, and need anticoagulation in the cancer patient who has the brain metastasis. Bleeding cancer is a melanoma germ cell, in my experience. What can you mention what is meant here by addressed in the treatment section when the patient has brain metastasis? Is that a problem?
It's a problem because people are worried about the risk of brain metastases bleeding.
Yeah.
Or actually any type of CNS sort of lesions bleeding. It's a problem without sort of a satisfactory solution because obviously there's no clinical trial of randomized trial in patients with brain metastases. And so the update has been in response to sort of a frequently asked question. Hey, I have a patient with lung cancer with CNS mets or breast cancer with CNS mets, and they have a DVT or a PE. Is it safe for me to anticoagulate? And so that's called out because it's an important clinical question that's often asked. But the answer is not quite that satisfactory. The answer basically is do as you would have done otherwise. Just be, but just be aware that there's a greater risk of bleeding. The text sort of gets into some more granularity, and I think in general it seems that bleeding. Intracranial lesions are always at risk of hemorrhage, but the hemorrhage is not substantially greater if you're on anticoagulation versus not. The two exceptions are, renal cell cancer and melanoma metastases, where there seems to be an increased risk of bleeding. But again, it doesn't outweigh the risk of DVT or PE. So keep that in mind. It doesn't change the answer, but it's simply a call out because it's an important clinical question.
Now, twice, continuing in the recommendation changes, twice in here, the mention is made of a post-operative patient. So, interestingly, I think before this comes along and the Khorana scores are folded into clinical trials, there's a recommendation, ASCO, or in the CHEST updates, which always come out with anticoagulation guidelines. If you're having abdominal pelvic surgery and you have a cancer operation for this, you should get, I think it was 4 to 6, now it's 4 weeks post-operative anticoagulation, therapeutic, or maybe I'm wrong, it could be either preventive or therapeutic, but something for 4 weeks. And we've found in a survey we did in the Penn system that's very infrequently followed and yet very frequently not a problem. The patients don't come back in with DVT PE very often. So how would you explain then the current update? What are we doing with a post-op patient who's had a cancer operation, surgery, abdomen, pelvis?
Yeah. So this recommendation is based on there were 3 different clinical trials looking at post-operative prophylaxis and extending out to 4 weeks versus stopping at 1 week. And all 3 trials showed that there was substantial risk of persistent DVT or PE persisting out to about 4 weeks. So the update, takes into account the results of those randomized trials and has this new recommendation. It's prophylactic doses. It's not full therapeutic doses.
Thank you. Prophylactic.
And,
good.
Yeah, and since you're talking about different anticoagulants, I want to clarify that it's low molecular weight heparin because that's the only data that exists in the postoperative setting. We have no data for direct oral anticoagulant.
Okay.
The prophylactic doses of low molecular weight heparin for up to 4 weeks. This only applies to abdominal or pelvic surgery. And even in those patients, it's only patients with high-risk features, and the high-risk features are listed as restricted mobility postoperatively, obesity, or a prior history of VTE. And then there's some additional risk factors like residual disease after surgery, which only applies to a minority of patients. So it's not for all cancer surgery. It's not even for all abdominal or pelvic surgery. It's for abdominal or pelvic surgery in patients who have high-risk features, like restricted mobility or obesity.
Okay, so then as I come to the bottom of this paragraph, to just on the heels of what you just said, it says patients undergoing major cancer surgery, so it doesn't specify location in the patient, undergoing major cancer.
Yeah, it does in the actual recommendations. If you go to the clinical question, you're right, it's in there. Yep.
And it also says before, I thought it interesting, before surgery, and so you're hospitalized, you're going to get surgery in a couple of days, or maybe the decision's made on what's the matter with you and what to do.
Yeah, so that's a great point. So this was actually a huge it's been a huge sticking point across all guidelines, and nobody quite knows how to address it. The before surgery is really referring to, when you're taking the patient to the operating room, that's when you give your first shot, like that day. Before, the morning, if you're operating on Monday at 11 o'clock, then at 9 a.m. you'd get, when you're being wheeled to anesthesia or something, you would get your first shot. In Europe, my understanding is that that's how it's always done. In the United States, almost everybody starts it post-operatively.
Yes.
The challenge is, ASCO guidelines are very vetted to evidence, as they should be. And the evidence is based on these trials of prophylaxis that were done, in the 80s and 90s. And they all started with the first dose being given preoperatively at varying time points, but preoperatively. And so we had tons of discussion around this. That's not sort of the clinical practice in the United States, but there's actually no trial, with one exception, and I'll come to that exception in a second, but there's no real trial of only starting post-operatively. All the trials of post-surgical prophylaxis were with the first dose given preoperatively. So it's hard to say do it post-operatively when you have no evidence to cite that, to sustain that recommendation. So hence the wording reads the way it does. The one exception is a trial of a drug called simuloperin, which at one point was going to be Sanofi's replacement for enoxaparin. It was sort of the next generation low molecular heparin. And it kind of died out because the direct oral anticoagulants, came into play, and people don't want to sort of go back to an injectable if they can avoid it. And in that one trial, simuloperin was started post-operatively, and the enoxaparin was started pre-operatively. And the rates were a little bit higher in the post-operative, arm. It wasn't a direct pre-operative enox versus post-operative enox. It was, different agents. It's a little bit messy. But the bottom line is there's no data that says it's safe to start post-op. I think a lot of people assume it. A lot of institutions do it. Many surgeons are worried about sort of the risk of bleeding if they give that first shot pre-op.
Right.
But by the way the trials were done, the first shot was given pre-operatively.
Okay. Well, so that clarifies well, because the patient probably will be pre-op for enough of a period of time to get a shot.
Right.
So what I'd like to do then, as we kind of bring it on home, is we've now covered the JCO recommendation, of which you were part of, ASCO update on thromboprophylaxis. I want to mention that some of the data on which this is based generated, and we'll have this in our show notes online, which I'll mention in a second, but it's the February 21st of this year, 2019, issue of New England Journal. There are 2 articles, and we've covered this in our previous podcast to remind everyone. Dr. Khorana was first author on the first one for the Cassini trial, entitled Rivaroxaban for Thromboprophylaxis in high-risk ambulatory patients with cancer. They had a Khorana score of 2 or greater, and there was I'm quoting from the conclusion, substantially lower incidence of these VTE events. And the second paper in that same issue was by Dr. Carrier, title, A apixaban to prevent venous thromboembolism in patients with cancer, and also a Khorana score of 2 or greater. This was apixaban half dose, 2.5 milligram twice a day. And again, they showed a decrease in venous thromboembolism. Would you comment again, Alok? There was an editorial that this drew, which largely agreed with these papers and recommendations that they generated, but there was a little caveat to not always, which I think you've mentioned, but if you could mention again.
Yeah, so in general, the two studies agreed with each other that if you took high-risk patients and you gave them a direct oral anticoagulant, either rivaroxaban or apixaban, that you would see a reduction in VTE. And the reduction was especially strong if you continued on the drug. Cancer patients are sick; they went off the study. There is the caveat. One caveat certainly is that any anticoagulation is associated with an increased risk of bleeding, and we always have to sort of weigh that against the benefit. And both studies showed a roughly 1% absolute increased risk in major bleeding. That difference was not statistically significant, but I just I like to reiterate. These prophylaxis studies are not powered for bleeding. They're powered for the thrombotic, the DVT or PE endpoint.
Yeah.
And to show a difference in bleeding when overall major bleeding rates are around 1 or 2%, to show a difference in bleeding, you'd have to have 3-4 times the sample size. So I ignore the p-value in this setting and say if there's a 1% absolute increase in bleeding, then we should accept that that's probably the correct point estimate.
Yeah, and I think that's reasonable.
Yeah, the other caveat that was brought up in the editorial you cite is about lung cancer patients. The treatment of lung cancer has undergone sort of a huge change in the past 10 years. There's a lot of targeted therapy that's being used. Mortality rates are improving. Patients are living much longer. And so whether these findings sort of apply to those patients or not is unclear. We did not do a lung-specific trial, so certainly that could be done in the future. But between Cassini and Evert and others, a couple of meta-analyses, multiple guidelines, I think the data is clear that cardiovascular events can be prevented with this primary prevention approach, which is essentially what we are talking about. We've updated the Cassini data with including arterial endpoints, and we have data now specifically on pancreatic cancer, where the absolute benefit is quite substantial, and there's no increased risk in bleeding. So I feel very comfortable with these findings, and I think it's an option.
Where is that published, Alok?
The total thrombotic rates and the pancreas paper, the pancreas abstract was an ASCO abstract. The paper is not published yet; it's in submission.
Okay.
But there was no increased risk. There was numerically lower bleeds in the rivaroxaban arm in Cassini in the pancreas patients. So there's clearly. You mentioned pancreas cancer at the outset, and
right.
I run the GI cancer program at Cleveland Clinic. A lot of my practice is pancreatic cancer. That's that's an easy decision to make. They're at really high risk of DVT or PE. Bleeding rates are certainly not numerically higher at all in this population with anticoagulant prophylaxis.
Yeah,
so I think that's an easy.
I couldn't agree with you more. And so you'd be comfortable taking from either of these two studies, the Cassini, the 10 milligram rivaroxaban versus placebo, or the Avert, where it was apixaban 2.5 twice a day versus placebo. So I certainly would be, and so it sounds like you would be as well in a pancreas patient.
Yep, absolutely.
So I think what we've tried to do with this podcast is to, again, highlight that we in oncology are addressing and considering worrying more and more about our walking wounded, as you said at the outset, who are at risk. Some say on the life of especially metastatic cancer patient, 20% VTE risk, which is not small. And so given guidelines like ASCO guidelines, the Khorana score, and these trials, we could consider the individual patient and his or her risk and try and give some prevention. These articles we've just mentioned will all be in our show notes on our electronic journal webpage at mdh.com/hematology-oncology, where 3 of our budding residents going into hematology oncology at Pennsylvania Hospital, Ronak Mistry, Sue Landy, and Emily Breyer, will do show notes so you all can see what we've said, and there'll be websites you can click to see these articles. So I think with that, I'll bring it to a close, Alok, unless you have something else to add that we missed.
No, thank you for highlighting this subject.
Well, you're very welcome. And again, thank you for joining us. You've all been listening to Blood and Cancer. I'm Dr. David Henry, and thanks so much for listening.
Welcome back to Blood and Cancer, the official podcast of MDH Hematology Oncology. I'm Nick Andrews. It's time now for Clinical Correlation.
I'm Ilana Yurkiewicz, and this is Clinical Correlation, a segment about the human side of hematology and oncology care. A diagnosis of cancer can feel like the ultimate loss of control. A person is now at the mercy of the infusion center giving them strictly regimented chemotherapy, at the mercy of the oncologist ordering blood work and scans, and most importantly, at the mercy of the cancer, which either will or will not respond to the treatment intended to stop it from growing. Most patients want to do everything in their power to beat the cancer, which is why one of the most common questions I have heard during my fellowship is about one of the few things a patient still has control over. They ask me, "Doctor, what should I eat?" I have had multiple patients where I later learned they cut out all sugar from their diet based on internet message boards saying sugar will feed cancer. One woman refused to eat a slice of her favorite cake on her 70th birthday. Many cancer centers are now equipped with full-time dietitians and nutrition centers that can help patients navigate these questions. The short answer of what I say in the office is that a diet good against cancer is the same type of diet we consider heart healthy. That is, high in fruits and vegetables, low in saturated fats. Beyond that, though, I say everything in moderation. The reason I say that is quality of life. I get the impulse. Diet is one thing a patient can control. For some, it helps people feel they did everything they possibly could, and that's an important piece of their journey and of closure if things don't work out. At the same time, I also say, please have that slice of birthday cake. Thanks for listening, and I hope you'll tune in next time for Clinical Correlation.
And that's a wrap on this episode of Blood and Cancer. Let's get to this week's show credits. Blood and Cancer is the official podcast of MDH Hematology Oncology. It's hosted by the editor-in-chief of MDH Hematology Oncology, Dr. David Henry. Clinical Correlation is written, recorded, and produced by Dr. Ilana Yurkiewicz. Blood and Cancer audio producer is Mary Ellen Schneider. All of MDH podcasts are produced by our editor-in-chief, Mary Jo Dales. Executive editors Denise Fulton and Kathy Scarbeck. Multimedia editor Terry Rudd. Blood and Cancer social media is produced by Kyla Clark. I am your audio engineer, audio editor, and the voice of MDH Podcasts, Nick Andrews. Thanks for joining us this week on Blood and Cancer.